We're going to have a panel now on the voice of nursing leadership. And as I introduce each of the panelists, if you would come and take a seat on the couch, that'd be great. Our first panelist is Linda Groh. She's the Executive Director of the Association of Perioperative Registered Nurses. As an anesthesiologist, I get to spend a lot of time with perioperative nurses, so I particularly appreciate everything they do. Linda has devoted her career to perioperative nursing practice, education, and executive management. Thank you very much for coming. Oh, I forgot to mention that you've got 35 years of experience. Oh, no, sorry. Lali Julinas, our next guest, has 35 years of experience. She's now the Vice President and Chief Nursing Officer for the VHA. Thank you very much for joining us. And our final panelist is Julianne Morath. She's the Chief Quality and Patient Safety Officer at Vanderbilt University Medical Center. She's been a recognized leader in healthcare quality and safety for over 30 years. Thank you very much. Our panelist is the one and only Forrest Gump, Chuck Denham. Thank you, Chuck. Thank you.
Well, I have to tell you, this is really a great privilege to be with these wonderful ladies here, and I really want to thank the leadership team of this meeting to give us the opportunity of having the voice of nurses, because really they're the end of the healthcare mile, and there are so many unsung heroes in patient safety, and here are three, and there are others like we often talk about, David Klassen, who will speak tomorrow, and others that behind the scenes are doing just fabulous work. And in the spirit of this meeting and really connecting everybody, and thank you so much, Ed, for really helping put the perspective and the patient family stories in place. These three wonderful women are going to share with us the voice of nurses. And in our dialogue together, we talked about what we really want to hear is, what don't we know about nursing right now that we need to know to get energized, to act now, and focus on these three areas that this conference is going to focus on tomorrow. So we're going to, in the spirit of the framework, and give them, they're all so eloquent, as you'll find, but we'll use this framework so that it can set us up for tomorrow, because I think it's really important that we understand from the nursing perspective where we are. I will share a couple of personal notes, though. Linda Groh was our partner in our first Discovery movie, Chasing Zero, and their nurses were absolutely fabulous, and the WHO checklist was terrific, and we had medical students that helped put that forward, and you know, that has been wonderful. Lili served on my group with the National Quality Forum Safe Practices and was a fabulous contributor to the national standards for nursing, and Julie was on my committee of the NQF, and one of the very few people that is a nurse, has been a chief operating officer of a hospital, and now is a chief quality officer at one of our major medical center, university medical centers, beating out many doctors who aspired after that position. And so these women are absolutely fabulous. So let's kick off and start with leadership. We're going to talk about leadership, and then practices, and then technologies, and then we're going to dig into these three subject matter areas tomorrow. So for Linda, what do we need to know that we don't know about the engagement of leadership with the view from nursing? You represent the perioperative nurses, the OR nurses, and maybe embed in your statement actually the constituency that you represent.
Well, AORN is an association of 42,000 members. There is 160,000 perioperative nurses in this country. So we actually set the standards and recommended practices for the practice that is engaged in your operating rooms all across this country. What's important about the leadership piece is that it is so important that the leadership of the institution empower the staff, the nurses and the surgical team, to actually speak out anytime they see an issue that would involve patient safety or welfare. And Dr. Swenson mentioned that, but I really have to emphasize that it is so important. It's important from the boardroom all the way down to the staff that they understand that they are accountable and responsible for delivery of optimal patient care every time to every patient.
Thank you. And I've asked our panelists, and you can tell how wonderfully disciplined that they are, to give us short 20-second sort of answers that we can come back to so we can finish on time, but really give you an opportunity later with video clips that may come from this, and perhaps even a proceedings article in the Journal of Patient Safety that could embody some of the detail and the citations that could support that. And coming to that, Lily, you spend a huge amount of your time as a cheerleader and a shoulder to lean on for our chief nursing officers across America. So you have a very unique perspective that you could share with the leaders here. What do we not know about what's going on with our chief nursing officers today in 2013, knowing that we're going to slam into gear here on accountable care?
Thank you, Chuck. And thank you for asking us to be here today and being a passionate advocate for nursing, because I know without you, we would not be here, and I want to thank you for that. And he's just the kind of guy that he does call me, and I do agree to do a whole lot of stuff.
She always says yes.
So, just to give you a sense of scale, which I think is so important here, with our 1,400 hospitals, 20% of all the registered nurses in the United States practice in our organizations. So I'm very serious about my role and what it means. What I think you might not know is that turnover is really an issue that we're going to have to deal with. We can't say that we put one thing in place and think that it's going to work. With one of the major search firms that we work with in our organization, we documented 40% turnover of chief nursing officers annually in the United States. For every CEO role that they have to fill, every CEO job search they have to fill, they get 300 resumes. For every chief nursing officer role to fill, they get 3. So when we think about what it's going to take to embed practices and technology and leadership into this safety arena, we have to consider how severe the turnover is and the fact that no one wants these jobs. And why don't they want the jobs? That would be something for us to really investigate and try to make change around.
Thank you, Lily. And I think as we go forward and talk about the citations of these numbers, I've asked the panelists to mention where they might be, but not go into detail, and then we'll have that for you afterwards. And I think one of the key issues is that for you CEOs in the audience or those that watch this later, that is a very important number, and we really need to develop our leaders, our nursing leaders, and give them the respect that they really deserve for this Herculean job that they undertake. It's really fun to talk to Julie, because we also, and the Massimo Foundation was so gracious to allow her daughter to be here as a medical student who is excited about patient safety. And we want to thank you all for extending the scholarships of many in the audience that have had a chance to come who wouldn't normally come. And it's great to have a family member here like that, Julie. And I'm sure she's so proud of you as well. Julie has been a terrific contributor to patient safety. Often written about it. She was in our recent movie, Discovery movie, Surfing the Tsunami, and really gave us a great close regarding the boards and the C-suite. Because you have two views. You've been a nurse, you've been a chief operating officer, and now a chief quality officer at one of our greatest academic organizations. Let us know what do we need to know of these two views, the view from the nursing and the view from the C-suite. What do we not know that we really need to know as someone who's a real expert in patient safety?
Thank you, Chuck. I would like to also extend my thanks to have my daughter Alex here. It's exciting to see a legacy kind of part. A view from nursing, and I think really all of leadership, is that leadership is both a noun and a verb. We tend to think always about positional leadership, but we have amazing leaders throughout our clinical environments, and often they're not engaged and not brought to the table as part of the problem-solving team. So I think that's a big piece, is to always know in your environment who you can tap into. Don Abedian talked about love your patient, love your work. That's the basis of improvement. That's the basis of safety. And I would suggest that those who do not have love, as they come to this work, because it takes passion, it takes vision, and love is the creative force, that perhaps they should be leaders in another industry. Because the stakes are too high, we have human lives in our hands, and we have the health of the public, and we're stewards of that.
Thank you, Julie. You know, you can see that these women are very eloquent. They come from a terrific base and a background of experience. So let's dive into some of the topics that are really critical that we're going to focus in on tomorrow, because we're not talking about general things. The wonderful planners of this meeting really are giving us some handles on some very specific areas, and I'd like to dig into those using the framework we talked about, leadership practices, technologies. I'd like to come back to Linda and talk about this issue of failure to rescue. I don't think any of us are aware of how big a problem it is and what a great opportunity that practices and technologies could afford us. What's the perspective from nursing on failure to rescue? What do we need to know that we don't know?
Well, I think, number one, the nurse is usually the first person that's going to be there and is going to be able to recognize when a patient begins to deteriorate. What you don't know is the number of times when a nurse calls a physician to seek some assistance and they hang up on them, they refuse to come, or they poo-poo what is being said or what the symptoms are being described. So it is so important for nursing to really understand that they have the responsibility to escalate that call to the next person that they can get to come to take care of that patient, because of the way that they are intimidated by some of the physician colleagues.
Boy, that is such an important point. And now as we talk about leadership practices, technologies, having the technologies that could give us the pattern recognition of the vitals and being able to have objective and not just interpretive issues would really help us to speak truth to power, because it'll take a long time for us to change a lot of the attitudes of our physicians. So I think that's right in the sweet spot of what we're talking about here. Lily, you spend a lot of time with your hospitals on performance improvement. What do we need to hear from you and your perspective from the C-suite and chief nursing officers? Failure to rescue. What can you share with us about failure to rescue?
And Chuck, I want to offer to the group the ability just to share everything that we found out from a dedicated effort in failure to rescue, where we spent a tremendous amount of time trying to implement failure to rescue teams in our hospitals. We have a number of publications that we're more than willing to share with you, including the top 10 lessons we learned from implementing rapid response teams. What I'd like to tell you about failure to rescue, though, is how hard surveillance is. The first patient that ever died on my watch died because I didn't realize what respiratory failure was. I was a young Navy nurse. I was running a 40-bed Marine surgical unit. And if it had not been for some very talented other team members who were able to teach me, I'm glad that I didn't have another failure to rescue death. Surveillance is very difficult. It is said that the best nursing care is actually invisible, because good nursing care means that nothing bad happens. But did you know, in a 12-hour shift, that the average registered nurse in the United States only spends 1.7 hours at the bedside out of 12 hours? Most don't realize the work that takes a nurse away from the bedside. I had the privilege of co-chairing the National Quality Forum Nursing Sensitive Measures Committee, where we were able to establish the measures for nursing sensitive care in the United States. And the hardest discussions we had were around the concept of how do you measure good nursing care. And in the 4 major areas that take nurses away from the bedside, which are medication administration, communication, hunting and gathering, and other, let's look for it, 3 of the 4 major reasons that nurses are not at the bedside can all be solved with technology. The evidence is clear. Where we lack are the strategies around execution. I don't want one more nurse to suffer the pain that I've felt. And my first patient that died because of a failure to rescue situation, I was at the age of 24. I'm 60 now. I have never forgotten that first patient.
So you've just witnessed the power of story, which is so vital to really wake us up and let us know what's going on. Combine that with the data. We know from the multi-institutional studies that the typical nurse walks 3 to 5 miles.
That's right.
On a typical shift. On a typical shift, they'll go to the nursing station 200 times. They'll go to the medication cabinet 100 times. Their time at the bedside with a patient averages 20 seconds. The reason we know that is by putting RFID badges on those nurses. We couldn't get the data, and we had to put 2 badges on them because we didn't know that they couldn't register them. And so that tells us that we need technology to help those nurses and really address this. So the question is to Julie, we have the data. We have the data. We know we've got a big issue there. What's your recommendation to us in this area on failure to rescue? Because you deal with the C-suite all day long, and you know the data. You've been a nurse, but there are the dilemmas of resource constraints and competing priorities. What's your message?
Production, fragmentation, and distraction has really eroded the safety boundary for patients and those who care for them. And unless we're able to error-proof our systems, engineer them correctly, and allow nurses to do what their duty is, and that's advocacy for a patient, one must be there to know their patient. But that human vigilance is not sufficient. It's required, but insufficient. And that's where our continuous monitoring and other systems that complement both the assessments of the nurse as well as the nurse's intuition about the kind of pattern detection that develops over time with experience needs to be there to support and back that up.
I think that's why this meeting is so exciting, because we have technology leaders from companies, great companies in America that Joe has pulled together. And it'll be hard to get everybody to agree to share their data. It'll be hard to find standards again, to work together. But you're hearing in this session with those that care for patients that we can't stretch them any further. We really do need to have integration of and interoperability and data that is available to us that can recognize patterns. We're flying our jets by hand, and we're creating self-induced oscillations, and we're creating all kinds of inefficiencies and lack of safety. And we've solved this in aviation. We've solved this in nuclear power. We need to solve it, and that's why this is not a meeting. This could be the beginning of a movement. And as Bill George, a good friend, would say, let's not waste a good crisis. Now, there's an invisible crisis that I didn't know very much about, and I had to kind of come clean with you and say, I really didn't know what a safety opportunity. Now, I'm a recovering optimist, so I'm going to say opportunity that safe blood use is. I just didn't know until great people like Ari Shander and others taught us about this. So we're going to cover that topic next and go back to Linda. Holy Grail opportunity. Here's an opportunity for us to reduce what is really a liquid transplant. We have graft versus host disease. We have extended length of stay. We have diminished success with cancer treatment. I'm a cancer doctor by training, had a big practice and I practiced for 12 years, and I look at the data and I'm going, oh my gosh, I don't think too many people really understand the opportunity. And the overuse of blood are in patients that only receive 1 to 3 units. So we could prevent a transplant in somebody that just gets 1 unit. So your perspective, because in the OR, this is where the decision is made, estimated blood loss, how much did we lose, did the patient need it ahead of time, and what about the borderline anemic patient that we could have delayed for surgery for 21 days and get them on iron? Your perspective.
Well, there absolutely is overuse of blood in surgery. It's amazing the number of times that just 1 unit is used, and there's really good evidence. That evidence goes back to actually the early 90s, and we still have not made the changes that we need to. Don Berwick is famous for saying that it takes us 17 years to accept change in medicine and nursing. That is entirely too long, because we are using a very precious resource, and we are exposing patients to potential harm. So we really do need to look at this. Now, there are some centers of excellence in this country that have solved this issue and resolved it within their institution. We need to learn from those institutions, we need to benchmark from them, and we need to use best practices in resolving this issue.
Lily, when we look at this issue, and now we know there are technologies for monitoring hemoglobin non-invasively, there are going to be more and more of these great technologies that will be non-invasive, that will really help us. We'll learn more probably about those tomorrow. Paul Jansen, that is here, helped teach us about this as we built our knowledge set. And as I head to the ASA annual meeting, I can tell you this is a topic that I'm going to be interested in. Lily, your call to action here, but also how do we get leverage chief nursing officers to make them a spokesperson in this area for safe blood management, and your thoughts there?
Well, I want to give you the message for action first, which I think is so important. Our hospitals are clustered into 13 regional healthcare systems across the country, and one of them has really taken up this topic in earnest. And what we've learned around making best practice common practice is the need for a spread plan, that we have to be planful and purposeful, and that the spread of the best practice doesn't just happen. We looked at what it was going to take, and it was technology that was helping so much in this particular cluster of hospitals identify the most appropriate patients that should get blood. And when at the end of the day, we looked at some of the measures after a very short period of time, not only were costs saved, was blood saved, but when the appropriateness of the blood was there, we were able to show that for patients with a hemoglobin of less than 7, the appropriateness of the blood administration had gone up 55%. So appropriateness was addressed, leading practice was addressed, as well as cost being addressed. But it took a number of issues, a number of best practice applications for us to be successful. So that the spread effort is only as effective as the plan that is in place. It doesn't just happen. It's not just a Vulcan mind meld. It's not just something that we say, okay, here it is, make it so. It doesn't happen that way. So I would ask, as you're thinking about this very important topic, is this topic an improvement strategic initiative, or is it just a focus, another flash in the pan, another part of the initiative overload that keeps us from doing the right thing every day?
Just to give you a little bit of a context, this is the most frequent procedure that we do in American hospitals. Mm-hmm. You know, the cost is a little over $500 to over $1,100 per unit. This is a direct cost to our hospitals, and in the C-suite where we're trying to cut direct expenses, it really is the holy grail, and they're big dollars vein to vein. And really the only, in the ecosystem, we fancy that term a lot this last year or two, the business ecosystem, the only group that really gets hurt are the blood suppliers. And to the degree that we can provide more blood and have it more available and more fresh, I really don't think that's a big negative consequence. So, Julie, your thought for this area and from your perspective, because you really can see things from C-suite and at the front line.
Comment about C-suite. The individuals in the C-suite really create the environment, both physical and psychological safety, the conditions of transparency, of trust, that sets the table for those in the front lines. And so often these issues are identified as frontline issues, doctors, nurses. So where I come to with that is that blood use is a major issue throughout the United States. It needs to be an institutional, strategic goal. We need to be transparent, not only within our own organizations, but across our organizations, across our country. When you do that, you begin to get interdisciplinary, multifunctional teams together that really look at the main issues in blood administration using the best evidence, training, monitoring and measuring things that are meaningful, that really gets at blood utilization instead of what just can be easily measured. Looking at appropriateness, waste, positive patient identification, both in collection and in administration, and having a constant feedback loop so that people are aware of how this precious resource is being used and that there's a safety net there for the patients that are receiving this resource.
So I'm going to ask the panel, we're on time, we're doing great. I'm just going to ask them because they're aware of the concept of an NQF safe practice, a national standard that could address the problem, frequency, severity, cost, and the benefits. The first question is there enough data? Absolutely, there's enough data to really argue the case. Would there be the case for an end-to-end approach of a national quality form like safe practice for safe blood use? You all helped me with it. We've updated them over the last decade. We look at all of the other areas where we've got ample evidence, where we could have some specifications, where we could have a structure and then have the evidence that tied to the structure and an end-to-end look. Believe that that's something that might be worthwhile? I'm seeing some nods.
Yes, absolutely.
How about the audience? Now that you know a little bit about it, some of you probably are real experts and know a lot. Show of hands, how many people would love to see more in the literature that would really quantify this? And show of hands. Okay, so tomorrow let's see if we have more. But I think here's where leadership practices and technologies, the majority from here, put their hands up. Let's shift gears now and talk about medication errors. Now, we've talked about this for so long. This has been at the top of our list, and we talk about the adverse drug events that occur in our hospitals, and in today's dollars, or the last couple of years' dollars, $8,250 per adverse drug event that occur in our hospitals. We've got some of the leading experts in the world here. David Bates wished that he could be here. He couldn't be here. David Klassen, one of our world's leaders, is here. We're so blessed to be working with him on the CPUE flight simulator. We know a lot about it. This is still right at the top of the list. Mike Henderson from Cleveland Clinic and I had a recent conversation. Ed, you and I did on the world issue. Medication management and adverse drug events from medicine errors are still a critical issue. Linda, your thoughts?
Well, I think, Chuck, that we really need to be proactive with this. I think for every nurse that's hired in our institutions, they should be expected to have a medication assessment. And that medication assessment should be geared towards the patients that they're going to be caring for. If they're in labor and delivery or in the neonatal unit, we need to make sure that the nurses are competent in the delivery of the medications that they're giving. Now, nurses are not only need to be competent in the administration, but they also need to make sure that they're aware of what the prescription, the prescribing, as well as the dispensing, and is that appropriate? So the nurses are involved in two different places for making sure that medication safety is employed in our institutions.
Fantastic. One of the key issues is the nurses really see when we're making mistakes and we're using short-acting narcotics and we're creating respiratory depression and we're making it difficult, right, for them to take care of patients that get so sedated. So it's a doctor, nurse, although this is a nursing panel and you rarely get a chance to have this kind of qualified nursing expert set to talk to, but really that is across the board clinically a big issue. Almost 20,000 preventable deaths this year to short-acting narcotics. So medication management, Lily, you and I have been batting our heads against the wall on this issue since I had hair.
Yeah, since you had hair, right.
That's right.
I'd really like us to consider the fact that high touch and high tech is not an oxymoron. It is absolutely doable. In addressing medical errors in one of our organizations, and this is part of that when I was talking about can we please make best practice common practice, one of our organizations has just dropped the bottom out of medication administration related medical errors by the implementation of a new role in the emergency department, almost a med rec tech, who does nothing but look at the past history related to medication of a patient coming in on admission, and then using the electronic health record and other technology is really able to put together a very simple template about what is really going on with that patient. The physicians love it because the patient coming in that they're now caring for, there's a much better chance of them fully understanding what's going on with that patient. The patients love it, the families love it because they have a printout from the electronic medical record of exactly what was accumulated in this initial assessment in the emergency department. And it seems so simple, Chuck. It seems so simple, this combination of the high tech, using the technology for documentation and feedback to the patient and family and caregivers, as well as the high touch, because this is a person who's interviewing you face to face, touch to touch, finding out exactly what's going on with you in terms of medications. You just feel like you're important. You feel like there is a caregiver who is paying attention to what you're saying. It's just astounding how we know so much of what works. We just need to make it happen. Can we please just take what we know and make it what we do?
Thank you. You know, as we look at, Julie, your organization, Vanderbilt, is both acute care and ambulatory care. And just some more factoids, we have 7,000 people that will become Medicare beneficiaries today. If one has 5 chronic illnesses that would be registered, no matter how slight, but they had 5 chronic illnesses, they're going to see 14 physicians, have 50 prescriptions, and have 35 doctor visits. Now, the continuity of care from acute care and back and forth, and the med reconciliation, and Julie, you were on the team that helped develop the safe practice. You know, this medication area is so critical. Tell us what we need to know from your perspective, because this is a huge problem, and people always want to look at the shiny new thing. It's still right up there in the top 3 issues, isn't it?
Those shiny bright objects often lead us down these rabbit holes.
Yes.
This is a chronic problem. It has a lot to do with the basics. And I want to just divert for one moment. It's been over a decade ago. I had the privilege of participating in the Salzburg seminars on global patient safety. And one of the things we found across over 26 countries was blame and focus on the individual to be universal and a barrier. And so when I look at medication safety, I start looking at it's time to step out of our silos. We need to look at the patient's experience and the overuse, underuse, and appropriate use of and misuse of medications across a continuum of care. Having technology as the platform to support our ability to track and understand, and reorganizing our systems so that there are accountable persons for a population of patients, that we really understand what that experience is.
Thank you. We'll come back. I think we'll have time because we're really doing great. You guys, aren't they doing great? They're great and on time, and I'm watching the time there, and and I think we'll have a few moments to comment at the end, but I do want to dive into technologies now and address these 3 areas. So we've talked about failure to rescue. We've talked about safe blood management and safe blood use. And now we've also talked about medication management and adverse drug events, which we know are still a crippling problem in terms of our economics and really bogging us down in the care that we're delivering. I'd just like to have each one of you comment regarding technology. So we talked about leadership. We talked about practices, and we dug down into each of the 3 subject matter areas for tomorrow. I think you gave us a great view from the nursing perspective. Now give us the nursing view on technologies. We have minimally invasive monitoring devices. However, we have lack of interoperability, which I think is your passion, Joe, to get the companies that are in this room to start to work with us as providers and kind of be courageous enough to cross the conflict of interest barrier and the sharing of information to save lives and save children's lives. And that is so attractive. But our nurses could really help us with this. So as I want to kind of go down the line and just talk about what can nurses share with us, and what would you advise this group in the room about what nurses could share with us about adoption of technologies? It might be that you're aware of the technologies, but nobody's listening upstairs. It might be that you're not aware of the technologies and need to have education about the technologies. I think all of us are just trying to learn because there's some fabulous innovations. Or it may be we need to be testing them. But Linda, technology and these 3 areas, pick any one or all of them.
Well, the operating room, as you probably all know, is an explosion of technology. We have seen so much change in the operating room involving technology. What's most important, Chuck, is that the education and training and competence that is needed in the technology and using the technology occurs outside the operating room, not in the operating room. So that is an important part. We're beginning to use simulation centers a lot for this training, and that's really good. But it is it is frightening to see that there are some cowboys that are very cavalier on what they will try in the operating room before they've really done some simulation. So I have some real concern about that. But one of the most important things about technology from a nursing perspective is that we see it as an adjunct to the care of the patient. Not a substitution, but an adjunct, because the nurse's knowledge and skills are still so essential. The basics are still so essential to delivering the safe care for the surgical patient.
What a great, that's a great commentary. And I know Peter Pronovost tomorrow will talk about some of the great work that they're doing at Hopkins with their innovation laboratories and learning laboratories and that kind of thing. As we go to you, Lily, and we think about minimally invasive testing and monitoring a patient all the way through their stay at the hospital, even though it might be more expensive, but help the nurses. Pattern recognition that could allow us to catch patients that that we could help before they get to a code, which is either dead in bed or a failure to rescue and through a code and catching it early. As a pilot, I still can't conceive of the fact that we don't have data and patterns recognized so that the workload could be compassionate care and loving the patient. It's hard to love the patient when a third of your time you're doing hunting and gathering, a third of the time you're documenting things, and a third of the time you're just trying to administrate the meds, and then, oh, there's a break there somewhere. It's very hard to really be able to do this, and that's where the technologies can help us. But any of the areas, Lily, and technology, what would your advice be?
And Chuck, as your experience as a pilot, testing that technology and learning it in a simulator, which we also don't have. I just had to get that word in there as well. But when we think about nurses and technology, if we want nurses to use technology, they need to be part of the decision to buy it and to use it, because nurses are much more engaged when they are part of the solution, inside the solution, rather than feeling like everything is being dumped on them. I want to make sure that we all bring up for these next 2 days that ugly word, accountability. Who's accountable for using the technology? Who's accountable for the education and skill training related to that technology? Accountability is such a conundrum. It is a misnomer, I think, around who's accountable for what. In the early 2000s, we had this notion that everybody's accountable. Well, if everyone is accountable, then no one is. If everything is important, then nothing is. And we know that societal oversight for accountability can work. In the United States, in order to operate a vehicle, you have to have a driver's license. And to get that driver's license, you go to school, you take a test, and every couple of years you pay money, you get your picture taken, and we're highly accountable because there are consequences if we don't have our driver's license. Well, the societal oversight for healthcare practitioners in the United States around a license is the same. We go to school, we take boards, we have to pay money every couple of years, we get our picture taken. Our driver's license and professional licenses are just as visible on a website right now. Any of you can go see my driver's license and my nursing license out there, highly visible to society. Why is it we're highly accountable for the performance of what we do personally with a driver's license, and yet from a professional standpoint, we can't even get professionals to wash their hands consistently. So we don't run stop signs, but we don't wash our hands.
I'm so glad you brought up the accountability issue, but I'm going to take it back to the leaders that are in the room, the hospital leaders that watch this video clip or are in the room. You can't be a hospital or a health system CEO and say, I hire good people and turn them loose. If I had $1 for every time I heard that from a hospital CEO, I could buy another home out here, and they're pretty darn expensive. I'm telling you, it's amazing. The ground zero in the war on healthcare harm is in the boardroom, not the bedside.
So there's
Ground
accountability
zero
in the
is in the
boardroom.
boardroom. It is absolutely in the boardroom.
Setting the standard.
And if the C-suite leaders do not want to learn about patient safety and quality, I think you were so gracious to say that they could move to another profession, and I think we should help them because, and I think the employers are going to demand it because they are shocked that the biggest safety risk of Union Carbide, you would think that the community would think that the C-suite was interested in that or Alcoa or anything else, but yet in so many of our hospitals, we think we can delegate away patient safety and quality. Then we tell the supply chain, take 10% out of your spend next year, even though safety and quality risk is going up, and then they buy a product that the nurses haven't even participated in understanding. And this happens over and over and over again. So my message to our C-suite is you've got to get in the game. Ground zero in the war on healthcare harm is in the boardroom, not the bedside. And you need to bring the bedside into the boardroom to participate. And I think we could save a tremendous amount of money. Going with the lowest cost product that is in a grid, and we choose that product and then forcing it on the nurses has failed over and over and over again. And I'll introduce one more concept, and that is our aging nursing workforce, right?
Yes.
Average age is close to 50, 49, 50, depending on which study.
State.
53 years old for teaching nurses. They're starting to get nearsighted. They have hearing issues. Some are not as technically astute as the younger folks. And then the younger nurses haven't really had the seasoned experience in caring for patients, although they'd be more technically astute. So they're the final link in that healthcare mile, and we really need to recognize that. So it's important that the C-suite really understand some of the issues at play rather than just commanding 10% out of our cost budget on equipment and technology. Technology, Julie, you are the person that probably has to go in upstairs and make the business case and argue the business case for things in safety and quality and have so many competing forces at play. But we have enough time. Tell us your message, but then I'd love to have you answer that question because we have a unique view as somebody who's been on both sides, and you're competing with other divisions of a healthcare system for a budget.
Well, for many years, I did not quantify or look at the costs of doing the right thing because I thought it corrupted the decisions that were being made for our patients. In different environments, you need to approach that in different ways. Being a recovering COO, I can no longer do that, and so do need to provide some justifications. I think the return on investment in these kinds of situations is quite clear. It's quite easy if you take the time to package it. We know balancing measures of capacity, length of stay, return on readmissions. These are all very costly to the healthcare environment and they're a burden to our industry. And so as we begin to tease those out, it's you can develop those maps. A colleague of mine from Vanderbilt is here in the audience, and he's a human factors expert and runs a simulation program. And one of the things that we have found that usability testing with new technologies in which the end users are involved, they get a chance to stress test whatever might be coming out. And then there's the ability, instead of imposing technology on existing processes and people, they can be integrated with and either are a platform for change or a enabler of the work that people intend to do. And so often, we don't take the time to step back and go through that rigor. And time and again, we've found that that's a really critical feature for success.
So you can tell you've got a pretty accomplished set of women here that are fabulous nursing leaders. We could take the last 2 minutes and 40 seconds, because pilots always don't want to land on time, and I'm watching the clock there. We could take these last minutes and talk about total cost of ownership, ROI. We could talk about clinical reengineering and impact calculators that could be tied to mapping the clinical, operational, and financial processes. We know how to do that. That's something that, I've been involved in 400 different products and companies over 30 years. What we haven't done, though, is we haven't really leveraged the love experience, the loving experience, the healing moments that occur between nurses and patients, and how vital that is to healing, how vital that is to care. If we could free our nurses up with technologies, with better engaged leadership, with better practices that are leveraged and enabled by great technologies, what would it mean if we could spend more loving moments in the healing experience of really ministering to patients in quality? We've talked about all the technical stuff. We've got 1 minute and 40 seconds. I want each one of you to just react to this issue of the mind, body, spirit, loving connection of healing and how important that is.
Patient-family engagement and the nurse engagement is so important. It makes all the difference in the experience. You heard some stories today, and they are replicated across this country every single day when a nurse does have an opportunity to spend those very precious moments with a family, with friends, and with the patients that they're caring for. And I believe it would make a big difference in the retention that we would have in nursing.
Lily, if we were able to leverage leadership practices, technologies, and free up a nurse's time for more healing moments and a more spiritual connection with our patients, what would that mean?
It would mean that we at all levels understand the healing trifecta, which is the head, the science, everything we need to know, the heart, we're understanding at the basis what care is all about, and the hand, having the skills and the acumen, the simulation, return demonstration, where we show that we get all three. The most effective leaders, the most successful leading practice organizations in our system are those who truly understand the healing trifecta of the head, the heart, and the hand.
Julie, in our last movie, Surfing the Healthcare Tsunami, Julie is so eloquent at tying together the emotional piece with the accountability of leaders. If we could free up our nurses for more of a loving and healing and ministering relationship at the front line, what would that mean?
We'd provide better care and we'd have had lower costs. I think for the last couple of years I've been working on joy, meaning, and creating safer health care. And to get meaning is doing work that one sees as significant, and joy is the derivative feeling as a result of accomplishing that. We've somehow lost that in many of our practice environments. And to be able to create and restore that, I think we would have more engaged staff that isn't turning over, and the staff that feels cared for is going to have greater energy to engage and care for their patient.
They're right on time, and I would like you to just share with me our thanks to this great group of leaders. Thank you very much.
Thank you.